That out of the way, I am very excited to welcome Scott Lorch today. He's going to be presenting Delivery Hospital and Perinatal Outcomes, the role of context and methods to address selection bias. Scott is a board certified neonatologist with additional training in clinical epidemiology and healthcare economics, with an overarching research goal to understand the root cause for variations in health outcomes and healthcare utilization experienced by high-risk children, particularly those born prematurely. He is a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania and holds a Christine Sandberg Knisely Chair in Pediatrics. Dr. Lorch currently is the vice chair of the Division of Neonatology at the Children's Hospital of Philadelphia and directs clinical and epidemiologic research for the division, overseeing a group of 21 physician scientists with additional training in both clinical neonatology and epidemiology and biostatistics. His research focuses on population-based approaches to study topics around quality of care measurements and assessments, sociodemographic disparities in health outcomes, and health policy and systems of care research as they apply to pregnancy and high-risk infant outcomes, with extensive experience in the development and application of advanced causal inference techniques to study these questions in large population-based data. He's currently a principal or co-investigator on 5 R01 grants and has mentored 39 postdoctoral fellows, including me, and 17 junior faculty and over 75 associated publications by these trainees. So welcome, Scott. Please take it away.
Thank you very much for that lovely introduction. Let me share my screen. Going from Teams to Zoom, so that's always interesting. All right, so thank you very much. Can you see my slides? All right, I assume yes.
We are seeing them in presenter mode.
All right, let me get out of that. Sorry about that. Let me do this.
That looks good.
All right, excellent. All right. My typical conflicts of interest, which I don't have any, and I'm not talking about drugs. So our research group really focuses on population health, which is the health outcomes of a group of individuals, including the distribution of those outcomes across different groups. And ideally, the goal of our research and for population health in general is to optimize these outcomes across all patients within a given area. And you see evidence of funding, growing funding of work in population health, both from the federal government, particularly CMS, as well as in insurers trying to decrease the cost of care for their participants. So we study moms and babies mostly because pregnancy is the most common reason for hospitalization in women ages 18 to 35. And high-risk infants have a high risk of both adverse health and healthcare costs. Essentially, for the approximately 1.5 to 2% of infants every year who are born with a birth weight less than 1,500 grams, they incur 35 to 40% of the cost of care in the first year of life and represent 10% of all costs from ages 0 to 18. So when we look at how these kids do, it's helpful to compare the US to other countries, and both other countries internationally, but also within the countries to understand kind of variations, and thus opportunities for improvement. So this is a recent study from the United Healthcare Foundation looking at the United States and how it ranks with infant mortality compared to 38 or 37 other countries of similar economic development. The United States is down here in the dark blue at 5.4 per thousand live births in 2021. That number has increased to 5.6 per thousand, which we'll see in a second. You can see the average infant mortality rate is 4 per thousand. It's shown here in this light blue bar here. And you can see that it's 33rd, with only several Latin America and South American countries lower than they are, but almost all of the Asian and European countries with lower rates of infant mortality. Similarly, preterm birth rates are very elevated in the United States. This is just a graph taken from a paper in Lancet Global Health in 2018, which shows the United States with a preterm birth rate almost 10%, more similar to countries like Belarus, and interesting Canada, and much higher than many other Asian or European countries. These rates, though, do not in the United States are not distributed randomly. This is a slide from the most recent March of Dimes action report showing the preterm birth rates first, with red being higher rates and green being the lowest rates in the US. And we can see that compared to the lowest state, which in 2025 was Vermont at about 18.2%, we have a preponderance of elevated rates in the southeast portion of the United States, as well as in the Midwest, with rates in all of these areas in the double digits, peaking in Mississippi, which in 2025 had a rate of 15% of all births. This translates to an elevated infant mortality rate. We can see here deaths per 1,000 live births in 2023. The darker colors represent states with higher rates, and we can see these dark purplish areas having rates of 7 per 1,000 live births or higher. Again, with a fairly similar overlap with the preterm birth rates that we saw in the prior slide. The highest rates are in Mississippi again at 8.9 per 1,000 live births, and the lowest rates again are Vermont and New Hampshire at 2.9 per 1,000 live births. So why is this happening? And we've dug very extensively into the drivers of these differences. This is a conceptual model that we put out, which links both access to care and utilization of healthcare services that might benefit patients, based on the Anderson a day model for healthcare access. And we're going to focus primarily on this section. And Maria asks, and so we're going to talk a lot about delivery hospital and utilization and how the both availability and use of risk appropriate delivery services translates into improvement in patient outcomes. We have other talks and other areas that we're interested in on the left-hand side of this slide. One of our recent grants is looking at hospital financing and ownership and how this relates to outcomes. But today we're kind of focused on some of our more published work on delivery hospital. We're going to talk, because this is an HSR talk, I had to do a little bit of methods. So we're going to talk a little bit about the methods that underpin the studies that you're going to see here. I promise there are only 1 or 2 slides, and there's no Greek lettering on them. Happy to talk more in depth if you would like those. But I think for a mixed audience, it's probably best if we focus on the results and have a little bit of understanding why we did what we did. When we get the first study that we'll talk about, we will get into a little bit more detail on what this method is, because it's kind of hard to understand the rest of the results without understanding that. But I promise you no Greek lettering in the talk. So we're going to talk about 3 areas. One is the data on the impact of delivery hospital and perinatal outcomes, and why selection bias, that is, sicker patients tend to go to the better or more desired delivery hospitals, really can interfere with getting an accurate assessment of the cause and effect of delivery hospital on outcomes. Then we'll talk about 2 other areas, delivery hospital and quality of care, and then reasons for state variations in the association that we're going to see in the first paper, particularly whether all level 3 NICUs are the same, and if they're not, how do they differ? And could they explain some of the variation that we're already seeing in the effect of delivery hospital and outcomes? And then other characteristics besides hospital level that are important for understanding the association between delivery hospital and outcome, specifically hospital volume. We'll talk then very briefly on access and kind of taking a 10,000 foot view of the healthcare system and how that affects outcomes as well. Because policymakers really desire to know not only the question of delivery hospital and outcomes, but how these hospitals fit into the overarching healthcare system that they're responsible for. So we'll talk about healthcare organization first. There's numerous studies, both in perinatal systems as well as both in perinatal medicine as well as adult medicine, that where and how care is delivered impacts the outcomes of patients. Where, how patients arrive to the hospital, what are the factors that optimize these outcomes? And these studies really focus on accessing healthcare, the geographic organization of the healthcare system, and then hospital and community factors that affect outcomes. So neonatal intensive care is a very interesting, high cost, high technology method of care to optimize the outcomes of high risk patients. It was developed in the early 1970s, primarily to manage prematurely born infants. It also now encompasses ill and sick term infants born to term gestation, whether that's from expected reasons such as congenital anomalies or for unexpected reasons such as HIE or infection, etc. Initially, because of the high cost of care to develop neonatal intensive care programs, policymakers suggested that they be centralized or regionalized. An early study from Ray McCormick in 1981 attempted to randomize which geographic areas received centralized neonatal care versus those that did not. And it showed potentially a survival advantage to infants born in a regionalized area. But they had to stop the study because, as we experience now, the control groups or the areas that were supposedly not having um, regionalized care um, got regionalized care, and the regionalized areas rapidly de-regionalized over the time period of the study. So today, neonatal intensive care is very heterogeneous, with some geographic areas having one central level 3 or level 4 NICU, and we'll talk about levels in just a little bit. Um, but then other areas where neonatal intensive care services are basically distributed across every hospital that delivers patients in an area. There are four primary levels of care. They go from 1 to 4, with higher levels, numbers representing higher capacity to take care of sicker patients. So level 1 is what we would typically think of as a well baby nursery with minimal capacity to manage sick patients for any length of time. And these hospitals typically only deliver patients who are considered low risk or have a gestational age of 37 to 38 weeks and greater. As we go up in scale, we see that these hospitals have a greater capacity to deal with sicker kids, topping out at level 4 NICUs, such as Rainbow, such as CHOP, which have all services, including the ability to put patients on cardiac bypass, ECMO, and have all surgical subspecialties involved. So the question that we have is, does it matter where high-risk babies deliver? Well, older studies suggest that there's a higher survival rate when preterm infants deliver at a hospital with a level 3 or level 4 NICU. The slide on the right shows the meta-analysis from 11 studies performed by the CDC in 2010, where the boxes represent the effect size, and the bars represent the 95% confidence intervals for each study. Larger boxes represent more patients and thus having a higher influence on the effect, which is down here as these stars. The top bars represent all infants under 1,500 grams. The bottom bars represent the extreme premature infants, and we can see that in both cases that the effect favors level 3 hospitals. However, observational studies afterwards, and all of these are observational studies, we can't randomize where patients deliver. Further studies after the 1990s to 2000s, which is really when the studies that were included in this meta-analysis were took place, found decreasing benefit of delivery at level 3 or level 4 hospitals. And many hospital groups were using these studies to pressure state regulators to basically allowing them to build NICUs of any ilk at any hospital that was delivering patients. So, one observation that I had early on with these studies is that um, it is very difficult to adjust for how sick the patients you are taking care of are. Now, the typical thing from a neonatology group is to say, my patients are sicker than everybody else. That's the answer that for everybody that we have. Um, and that may be true or it may not be true. Most of the early studies utilize gestational age and looking at gestational age differences, and that was sufficient to account for these differences in patient case mix between, let's say, high level, level three, level four NICUs and lower level two hospitals. But there are also many unmeasured factors that go into where patients may be transferred or the types of patients that these higher level hospitals may take care of. These include things like fetal heart tracing information or information about the physical exam of the patient that is not recorded in a either electronic health record or in a population set of data that I'll talk about in a second. There may be severity of illness information that is not available in either ICD-9 or ICD-10 code, or even coded in the um, medical chart. So, for example, chronic hypertension may reflect the patient who has a systolic blood pressure of 140 over a diastolic of 90, or may represent somebody who is uncontrolled with 180 over 120, which instinctively tells you that that's a different patient with a different risk of an adverse outcome during pregnancy, but we have no way of really measuring that. So we set out to look at data from three states in this study, Pennsylvania, Missouri, and California, where we obtained information on all births from the birth certificates in these states over 12 years for this study. It's now 10 states, 25 years worth of data now, but in this study, it's 12 years, three states. We have birth certificates linked to death certificates of the infant and the maternal and infant hospital discharge record, which is the basically the UB92 or the billing record that you fill out or you have a coder fill out to submit both to the state as well as to the insurance company to get paid. That gives you a population of patients that delivered and received care in a state for a given year. And so it gives us the power to really see what's going on at hospitals throughout the state. And because we have not only their birth hospitalization, but subsequent transfers of patients, we can actually assess until hospital discharge what the outcomes of these infants were. So in this slide, I show several characteristics of patients in Pennsylvania who were either delivered at a level three or level four NICU, who had an average annual census of 50 or more infants with a gestational age of 32 weeks or less. That's shown here on this left-hand column. On the right-hand column are the infants who delivered at a hospital that didn't meet one of those two criteria. They meet both of those criteria. For this study, we looked at infants born 36 weeks and below. And what we see is evidence of measured selection differences. So the right-hand column, so these columns show the data for, let's say, birth weight and gestational age, as for example, the first two rows. The standardized difference, which is in the right-hand column, because all of these are p less than 0.05, but the standardized difference gives you kind of an idea of how different are the patients for that characteristic in these two groups. The goal is to have a absolute value less than 0.1. Ideally close to zero, which would suggest there's really no difference between these two groups in that characteristic. We see some pretty overly large numbers with birth weight and gestational age having a standardized difference of about zero point 0.4, which is about 0.4 times the standard deviation, which is a rather large difference. We also see differences in sociodemographic characteristics such as race, ethnicity, or insurance status. If you look down here at the very bottom for complications of pregnancy, we see significantly higher rates of all these complications of pregnancy in the patients who ultimately delivered at a high level, high volume NICU. So, to account for this, we did something called an instrumental variables approach. So, 2 minutes on that. The problem that we have is that we have a treatment here where you deliver and an outcome, Y, that is affected by what we're arguing unmeasured variables in our data. And so we already have evidence of measured differences, and we suspect that those differences are even greater than what we have data on for these patients. So what we are the goal of this project then is to not use where you delivered, but to use another variable, Z, that is influences where you deliver, but otherwise is not affecting either the outcome, Y, or these unmeasured variables, U. It's hard to find these, but if you do, it can then mimic a randomized trial, which is the ultimate in an instrument. The random number you draw to determine treatment, the random number is Z, the treatment is D, and that random number determines whether you get the treatment or not, ideally. And otherwise, it's just a number. It should have no impact on outcomes. It should have no impact on these other unmeasured confounders. And so, what we're trying to find is other variables besides a random number, which we can't do in this situation, that are influenced where you receive treatment, but is otherwise unaffected by other either the outcome or these unmeasured confounders. And what we have found, as in many other health services studies for these kind of structural hospital level kind of care, is that this travel distance here, particularly the difference that a person in a given zip code may reside from a high level or treatment hospital versus any other hospital in the data set. That the closer you live to the high level hospital, the more likely you are to deliver there. And that kind of makes sense. I have 3 kids. We chose to deliver at a much closer hospital than driving into Philadelphia to where I work. And so what we calculated for each zip code was this differential distance between the high level NICU and the nearest delivery hospital. A negative value, which is shown here in the first quartile data, which is negative 1.5, means that the patient lives 1.5 minutes closer to the high level treatment hospital than it does to any other hospital in the data set. For our furthest away, these patients live on average 39 minutes further from a high level hospital than they do from their closest delivery hospital. And many of these are rural communities, but many of them are not. Many of these are patients in suburban areas in the Philadelphia or California, or Los Angeles or San Diego region that have a delivery hospital with a level 2 NICU attached to them. And we can see that, at least in Philadelphia, and it is for the other 3 states, 2 states as well, that the closer you live to the high level NICU, the more likely you are to deliver, which we can see goes from about 80% in the nearest quartile to 23% in the furthest quartile. So while not the perfect randomized study, it's still a improvement. It still has a relatively strong association with delivery hospital, and controlling for other sociodemographic and geographic characteristics is unlikely that people choose to live close to a high level NICU because they think further down the line they're going to deliver a premature baby. So there is some face validity that this variable kind of pseudo randomizes the population and thus controls for not only measured differences in the population of patients who deliver at a high level versus low level NICU, but also controls for these unmeasured differences. So we can sort of look at this by looking at again, what we saw previously, the unadjusted differences in who goes to a high versus low, higher level NICU versus another delivery hospital, and then compare the when we use the instrument. And we did a matching study, which I'm not going to get into much, but you can basically look on this slide here, and we can see this is actually people, they didn't necessarily deliver at a high level NICU, but they lived close to a high level NICU. And then people who lived further away. And we can see that overall, these illness and other sociodemographic differences sort of disappeared. When we look at the outcomes then of delivery hospital and outcome, we can see the unadjusted rates, and we're showing risk differences on one column and relative risk on the other. Anything positive means that there are higher rates of each of these complications at the high level NICUs, and relative rates risks greater than one reflect, again, higher rates and a higher likelihood of having these outcomes on an unadjusted scale for premature infants who are delivering at a high level NICU. So we can see this evidence of selection bias with higher rates of every outcome, both death and morbidity, at the high level NICUs in each of the three states. But as we'll get to for the last 30 minutes of our talk, the differences in rates vary between states. However, when we did the instrumental variables approach, and I will show this on another slide in a second, we find that there is a marked and beneficial effect of delivering at a high level NICU with improvements, and we'll see here in a second, of between 20 and 60 to 80% improvement in outcomes for premature infants delivering at a risk appropriate, high level, high volume NICU. But I also put in on this right-hand side the results when we would do it the traditional regression way, where we put in all measured confounders that we have in our data set. What happens to the results? Well, we see that in general, from death at least, it's now not harmful to deliver at a high level NICU, but there is no benefit that we found. And we continue to find higher rates of all morbidities for patients who deliver at a high level NICU. So the difference between the instrumental variables approach and the propensity score or any other kind of matched measured covariate approach tells you how much unmeasured differences we have in the case mix between the high level and lower level units. But what we also found interesting was that this effect is not consistent or homogeneous across states. This graph just shows the effects of delivering at a high level, high volume NICU in Pennsylvania, California, Missouri for in-hospital mortality, neonatal mortality, which is just at the 28 days of chronologic age, and one common morbidity of premature birth, which is bronchopulmonary dysplasia. For ease, I did not put it on a logarithmic scale, so you're going to see a weird effect here where the confidence interval does not bound the effect on in Missouri. But what we can see is that for particularly mortality, a pretty dramatic difference where Pennsylvania was about a two-thirds reduction in mortality when you deliver at a high level, high volume NICU versus about a 20% reduction in mortality in California. And in neonatal mortality, only Pennsylvania showed an effect. So this led to a number of other studies and grants really asking why do we have this variation? And so potential reasons include variation in care quality, something about the hospitals or the patient populations that exist there, differences in hospital characteristics beyond level. So a level 3 or level 4 NICU in, say, Pennsylvania is not the same as one in Ohio. That's not the same as one in California, or differences in access to care. So we'll spend the next 20 minutes or so going through some of the data that we have on this and trying to ask why are we seeing these state variations. So first of all, is care quality. So there's ample evidence from Vermont Oxford that care quality varies widely by region and by hospital. So first by region, this is a study from Jeff Horbar's and that was published in 2019, which showed the weighted score of their baby monitor score, which is a quality of care measure developed by Yoke and Profit, which consists of 9 measures of care, predominantly outcomes such as pneumothoraces, mortality, but also some process measures such as hypothermia at birth and breast milk receipt at hospital discharge. They then transform these scores and report basically a Z score. So positive scores mean that they have better quality than the average hospital in their data set, and negative scores mean they have worse. This study just shows the weighted means for the 9 areas that they studied, and you can see wide variation with much higher quality of care as measured by this scale in the Pacific West and the New England areas, and much lower than expected ranges in the East South and West South Central, the Southeast portion of the country, and the Mountain Time Zone area. They've also shown variation, though, within individual hospitals. So I like to show this slide, which initially was showing the improvement in outcomes for patients here less than 28 weeks, infants born at one of the almost now 700 Vermont Oxford Network hospitals in the United States between 2005 and 2014. The orange bar represents the 50th percentile hospital value for first mortality shown on the left and chronic lung disease shown on the right, and then the 10th to 90th percentiles shown as the gray and blue dotted bars. So we can see improvements in outcomes over these past 10 years. But I also point out that the variability between hospitals is still remains fairly wide. As you can see, if you look from 2005 to 2014, these bars between the difference between the 10th and 90th percentile is relatively high, both for mortality and chronic lung disease. And we can see from a slide that I had from a quality assessment chapter that I wrote in for neonatology textbook in 2021, this standardized difference has remained constant throughout the 10-year process, suggesting that there's ongoing variations in outcomes for level 3 NICUs. So one of the issues that I have about quality and quality measurements is what is quality? How do you measure it? And there's a lot of different ways that you can do it. Either measure it based on your outcomes of care, how did you do? The processes of care, what did you do or didn't you do? Or sometimes even structures of care, such as you have a high level NICU and therefore you should do better. We have little data on how quality measures and levels of care relate. So Betsy Salazar, one of my mentees, now a junior faculty member, set out to look at quality for moderate to late preterm infants. And since we've done a lot of this work, I'm going to use this as an example of where quality and levels of care relate or they don't relate. So she set out to create a composite measure of quality of care for moderate to late preterm infants modeled on this baby monitor metric. She used these 9 measures. Most of these are in baby monitor. The only differences are the weight score and then the length of stay percentile, which was used to kind of just get at kind of general unmeasured differences in kind of the care that these moderate to late preterm infants received. She found some interesting things. First, this slide, which shows the correlation for each of those 9 metrics and the total score on the y-axis. So each metrics here, I'll just use pneumothorax, which is in the middle. The weighted Z-score for an individual hospital shown on the x-axis, the median, the MLP score is shown on the y-axis. And what we can see is that there's a lot of variability. Hospitals that do well in one measure do not necessarily do well overall when you take all of these other 9 measures, 8 measures together. And so you see here, for example, survival has a correlation of only 0.19. So it looks kind of like a Jackson Pollock painting, kind of splattering everywhere. Hospitals that do very well with survival may not do well with other measures, versus human milk receipt at discharge, which has a much more linear association with the total score. What's interesting is that we found that the MLP monitor score shown on the y-axis only had a modest correlation with the baby monitor score for the extremely and very preterm patients on the x-axis, with a correlation which is 0.17, but means that if you know the baby monitor score, you really only know about 18% of the variation in the MLP score because it's R squared. So you have to square the 0.47. What's interesting is that when we looked at levels of care, we found 2 things. First of all, this is the MLP. This is the total score. The MLP monitor score is shown on the left on the A panel, and the baby monitor score is shown on the B panel. We had to use the levels of care as defined by Vermont Oxford, which is really level two hospitals shown as the type A with restrictions on ventilation, type A, which is really like kind of low level threes, up to level four hospitals shown in that's type Cs. We can see as a box and whisker plot with median shown as the bar in the middle of the box and then the interquartile range is the top and bottom of the box. And kind of really the third to 98th percentile is the whiskers. Two things. One, level care was associated with the MLP score, with higher level hospitals, interestingly, having a lower quality score than the other lower level hospitals, but no association with baby monitor. And secondly, I want to draw your eyes and attention to how wide the variations are within each of these level types. This is for all. We see similar for when we looked at each component. And what I want you to see again is the wide variations in hospital performance across within each of these levels of care. You see that not only for MLP, but also for baby monitor here. So, what this data really suggests is this conceptual model of care. So, you may see that this looks like the Donavidian model for healthcare, where the structures of care that you have in place um, influence the processes of care that you receive, which then influence patient outcomes. Quality of care seems to be a moderating factor of these relationships, not necessarily driven by levels of care, but something somewhat independent of this level or structure of care. All right. So the other question we had are all level three NICUs the same? And one important piece to realize is that we've gone through iterations of levels. The levels that I described in the previous study, the one through fours, are what we've had since 2012. But prior to that, in the 2004 APB guidelines, the level three hospitals were really broken out into this ABCD kind of level, which was a little more nuanced in terms of their health and health outcome, in terms of what they could take care of reasonably. So this led us to ask the question, are level three hospitals all the same, particularly now that we have this kind of large, potentially heterogeneous population of hospitals that are taking care of patients? So one of my current fellows set out to do this with something called the latent class analysis. So I promised one slide on kind of what we're doing. So this is basically where we take all level three hospitals and take a whole bunch of characteristics. And you'll see it's going to be including volume, the volume of very low birth weight infants, how likely you are to transfer them, how likely are you to ventilate them, how likely are you to do surgery on them, and use these characteristics to kind of group hospitals into classes. These classes can be thought about as unmeasured, but are observed through these characteristics that we use in this study. If all level three hospitals are the same, you would expect to have one latent class. If there's differences, we expect to have more. And that is what we found. Instead of having one heterogeneous NICU, level three NICU, we actually have five groups as represented by the different slides. So these are all hospital years in our state data. And what we found is that these level three NICUs varied widely by volume, which are the first five slides here, the likelihood that they ventilated patients with the number of patients shown on the x-axis or the y-axis here, and the number of surgeries that they do. And you can see they go from low volume, really don't ventilate hardly anybody, patients in these 3A red group, to um, high volume, high ventilation, high surgical groups, these blue and purple bars. So you may say, what's different about like the blue and purple bars, the D and E, or the A and B groups? And that included the likelihood they transferred patients out, where we see that the blue, the 3D hospitals were much more likely to transfer patients out than the purple bars. We're actually looking into what this means kind of on a larger scale. But what's interesting about these groups are that these groups don't have the same outcomes. This slide shows the unadjusted and adjusted outcomes for in-hospital death and major morbidity. Sorry about that. Um, for the five groups, remember the 3A groups are the lower volume, low level hospitals that don't ventilate many patients. And you can see that their unadjusted and adjusted rates of death are about 20 to 40% higher than, and in fact, up to almost 60% higher than the high level, high volume hospitals 3D and 3E. Interestingly, because there's more mortality, we see that mortality is a competing outcome for major morbidity. So we see more morbidity in the level 3C, D, and E hospitals compared to the A and B hospitals. This is not surprising because we have prior work which suggests that NICU volume is a key driver for morbidity and mortality in level 3 and level 4 NICUs. This is a study that Karen Phibbs and I did about and published last year, which shows the number of very low preterm babies treated at a hospital each year on the as a row, and on the x-axis the effect size and the 95% confidence intervals for each of these volume classes compared to the 100 plus hospital group in a given year as a reference group. And we see mortality has a threshold between 50 and 60 for improvement in outcomes. And morbidity actually has a kind of improvement, but still significantly higher rate of morbidity in hospitals that treated even 90 to 99 compared to 100. Now, what we did in this study, because we couldn't really account for we couldn't find an instrument to account for unmeasured differences. But we know that because volume is associated with level, that higher volume hospitals are typically treating sicker patients. So what we did was we put in a fixed effect and used 20 years of data and basically asked the question, if a hospital changed its volume, how did its outcomes change in response to that? And what we interestingly found is we show as in this graph is that hospitals change their volumes actually not infrequently. We don't see a nice linear bar here. What we see is a lot of variation, particularly in the lower volume, but even in the higher volume hospitals. Um, where some stay the same as if you can see my arrow, it's pointing at 100 hospital throughout the time period, but many hospitals having improvement or decline in volume over this time period. So if you place a variable in for hospital, this accounts for these non-changing characteristics of the hospital over time. And then, like I said, asks you what happens if you change volume within the hospital, what would happen? And that gives you kind of a stronger causal effect than just putting all the hospital years into a model and trying to control for that. We did it multiple different ways and found no difference depending on what the length of time we put this fixed effect in. What was interesting is in this analysis, because level does not change all that much, um, adding level of care to this analysis didn't really change the volume outcome relationship. So it does suggest that all level 3 NICUs are not the same. And this heterogeneity may result in differential effects of, let's say, of state policy for levels of care, which I show here, the states that have such policies on the right-hand side of this slide. But really ask the question, what structures and processes of care are needed to optimize a specific type of patient? Okay, so finally, for the last 5 minutes or so, I want to talk a little bit about hospitals and the larger healthcare system. Delivery hospitals don't exist in a vacuum. What drives patients to choose to deliver to a hospital, whether hospitals even choose to deliver patients, is really a complex interplay of a number of factors, including financial incentives, the supply or the number of potential deliveries in a given area, and then other things such as fixed costs, which we will talk about in Philadelphia really quickly. This is important. This is data from Sarah Hanley and our team, which looked at how do we get OB care in the United States. The left-hand side shows this with hospital volumes shown from pink as the smallest hospitals to light blue as the largest hospitals. And what I want you to appreciate is that delivery hospitals are not distributed randomly. Not all states with the same characteristics have the same practice. Compare Iowa here to South Dakota right next door, and that there's an awful lot of very small hospitals delivering small volumes of patients, particularly in rural and non-core areas in the United States. Access is important. And what happens to this access to care just to get you to the level three hospital is really important. If you look at these patients, if you live in rural South Dakota, how do you get to the risk appropriate hospital, either in Sioux Falls or in Rapid City? How do you do that? And so it's really important that we think about the ways that patients get into the system and then get sorted into the hospital that provides the most appropriate, risk appropriate care for them. So we've seen over time that OB services are declining in the US. This is just a slide that we have in the number of closures, both facility closures shown in red that delivered OB services, and then a market increase, and we've seen this continue in hospitals closing their OB units, but otherwise remaining open, shown in blue. This is accelerated after COVID, where it was shown that having a bed for an adult patient typically makes more money than it does for either a pediatric or a maternity care patient. And we showed, at least in Philadelphia, which has shown a decline from 19 delivery hospitals in 1997 to now 4 in 2025. We looked at older data, initially about 10 years ago, showing that these closures in these areas have adverse effects for babies. We showed initial increase in death from about 40 to 50% in the 3 years succeeding the first set of closures in Philadelphia, that ameliorated over time but did not improve, which was another hypothesis that we had because you're closing in many times smaller volume hospitals. We didn't see improvements in outcomes, suggesting that patients are having difficulties getting to the hospital um, to deliver patients, and there's an access burden when you close these hospitals off. What's also important to realize is that state policies influence both the delivery of care pro and con. So this is data we did, which looked at whether states needed certificate of needs to open up NICUs and what the effect of such certificate of needs were on delivery of services. So we can see that in states that had a certificate of need, did not have a certificate of need, they had about a 2 to 3 fold higher rate of level 2 and level 3 NICU beds, and about a half per thousand increase in infant mortality compared to states that continue to have a certificate of need. Right now, there's about 25 states that have gotten rid of their certificate of need programs, and more coming every day as they are barriers to hospitals opening up NICUs. And it does suggest that kind of increasing care, so having more access, may be detrimental, just as having less access may be detrimental to patient care. And this slide just shows the decline in patients receiving care at high level, the blue NICUs in all regions of the US, and an increase in the number of patients receiving care at the lower level, lower volume hospitals in the Vermont Oxford data, shown as these pink lines over time. So, in summary, I think we can see that delivery hospitals, shown here on the right, are one key piece to the kind of optimizing patient outcomes and in a given geographic area over a given geographic time. And that where and how you receive this care is very important. Because you may find that different interventions have different and potentially unexpected outcomes than what you potentially hypothesized. And that it is really important that we think about, from an HSR perspective and methodology perspective, the ways that we use these observational studies to find the most accurate effect of an exposure on an outcome. Typical regression analyses may not suffice to account for the differences, particularly selection differences, in patients receiving care at a specific hospital. And finally, I like this slide because this is a slide from Lancet, which is arguing that it is time for public health to take a wider set of approaches and focus on the systems, the complexity of the systems that we observe and how patients receive care over time. Something that we talked very similarly with also in a 2019 viewpoint that we stated, where you've got to thinking about both mom and baby and about how these systems really evolve both from the hospital all the way up to the kind of global systems of care that overarch how patients receive care um, to really optimize the outcomes and address those differences in adverse outcomes that we saw in the first set of slides. I think all of these collaborators, I've highlighted some of the folks that assisted in the data that we have here. Um, my contact information is right here. My brood is right here, who were happy they had a 2 hour delay yesterday for the snow, and I'm happy to take any questions that we have. I will probably stop sharing so I can see the slides, or you can just tell me, Anna Maria, what you would like to do.
Yeah, we don't have any questions in the Q&A right now, so please,
Okay.
if you have questions for Scott, feel free to put them in. I will take moderator's prerogative and ask first question. I think that dynamic tension you described between, improved care in higher volume units and concerns about quality in lower volume, and yet um, balancing that with access is very much relevant in Northeast Ohio as we're continuing to like envision and re-envision our level 1 and 2 access. And in general, do you have words of wisdom? And is there a mathematical approach, statistical approach to sort of optimize those competing trajectories?
You raise an extremely important question. So I'm going to answer that with some unknowns. What is the maximum travel time that you would say is appropriate for somebody who's in labor? That's the first question. We don't know that answer. Um, and secondly, it's also though access to any care, but it's access to the appropriate care. So I think, and then thirdly, our rural communities, and my geography in Northeast Ohio is a little, I'm sure you can go far enough where you have some rural communities. Um, how do they differ from the urban community? So I will say that the volume outcome piece, I think, is food for thought in an urban community where you have to go 5 minutes down the road to get to another hospital that delivers somebody. Okay. That is very different than having to make a very tactical decision about whether somebody can get 4 hours from a delivery hospital to the nearby hospital. And we also, though, have to balance that 90% of births are low risk. And as we showed with Betsy's work, it may not be the best thing to be the healthier kid in a sick unit. Um, well, I didn't show the outcomes, which were the best for like a moderate late term baby in a very large level 2 NICU, not at CHOP, where I guarantee you, well, not at a higher level hospital, I would go to say. So all of these things have to be kind of weighed in thought through. Unfortunately, we're not seeing a massive increase in the number of people wanting to open a level 1 or 2 delivery service. What everybody wants to do is open a 5 bed level 3 NICU, 10 minutes down the road from a hospital that already has a 50-bed NICU. And that is a different piece altogether. And I think there's not a lot of evidence that that is a beneficial piece, particularly when you see that the proliferation of NICUs, like I just said, typically are in communities with higher SES, higher rates of private insurance, and thus is an interesting kind of dynamic of why they're doing that. I'll end this question though with kind of a thought process. There are two European countries that have very much restricted obstetric care in their countries, Portugal and Finland. Finland only has 11 delivery hospitals in the entire country, and only five that have NICUs. Portugal basically said you had to have 2,500 deliveries or more to deliver, except in one situation in both. The Azores have a NICU and a delivery hospital, and the very northern part in the Arctic Circle of Finland has a delivery hospital and a NICU. And and they didn't have any data. They just said, it looks like it's not a good idea to to make people travel this far. So we have talked about how mathematically we can do this. It is very complicated because when you start to look at where people choose to deliver, you discover that it is very complicated. And people do some very interesting things like bypassing a close nearby high level, high quality hospital to go deliver at a low quality, low volume hospital. It happens quite a bit. But I think that's really the tension that's going to have to be looked at very carefully and with very careful data to kind of weigh those two pieces.
Thank you so much for that thoughtful reply. Oh, I see one question just popped up from Sarah Ronas, who says, really struck by your final comment about system complexity. Curious if you were aware of or could speak to any efforts to apply systems dynamics methods to model potential consequences out of some of these decisions regarding where and how many units should be.
We're starting to see that. I have not seen papers yet, but I've seen abstracts, whereas people are starting to do, for example, using logistic software from Walmart and Amazon, and asking, can you apply that to hospitals and how they deliver care? I will say that it goes back to the Anna Maria's question, though. Those are unless you put in, like, patients don't like to travel very far, that choice of that caliper of how much of a negative it is drives many of these questions. Now, that said, we have an abstract that we just put in. There's a grant that Jochen Profit and Jeanette Rogowski that I'm on have, which is asking the question of networks. So it's a little different, but something somewhat similar, which is applying network science to these transfer patterns. So really saying, not saying should you have a NICU or not, but once you have one, how do you get people, how do you sort through this? Because, for example, in California, there's examples of two very disparate networks. Sacramento, where basically wherever you deliver, if you have a high risk baby, they all end up at Davis. They don't pass go. They go straight over there. Versus Los Angeles, which has a very large number of level two and level three units. Patients may end up going to two or three places before they ultimately get to the risk appropriate care to get ECMO. And I don't know what you guys see, but we see this sometimes where we see a bad PPHN or get born at a level one hospital, ends up at, get moved because they're not yet that sick to the level two hospital, then some level three hospital that's when they're managing, they go there, they put them on nitric, and then they fail, and then they end up at us. And that's probably inefficient in the grand scheme of things. The challenge is, of course, knowing which of those level one and level two patients needed to bypass everybody else and which ones could stay out. So there's always those trade-offs. But we're starting to see some more sophisticated systems types of approaches, taking from other industries and other models to the perinatal system, which is much, much more complex and centralized than adult care, which is what I will say. Um,
Thank you so much. I think we're right at 12 o'clock and I don't see any more questions. So I want to thank you so much for joining us today
no
and
problem. Thanks for having
really
me.
appreciate your experience and data.
All right. Thank you very much.